So the topics we're going to cover today include gastroesophageal reflux disease, or GERD as I'll call it, peptic ulcer disease, or PUD, nausea and vomiting in general. We'll get into the specifics when we get to that section, and then gastroparesis. Just to let you know, this is a very high-level overview, as this is a lot of really dense topics, but I kind of wanted to just highlight the drugs that you might see most often and what you need to know about each of those. First, we're going to talk about GERD. Symptoms associated with GERD include heartburn, hypersalivation, and regurgitation. Diagnosis is if symptoms occur greater than 2 times per week. And the treatment algorithm is first to discuss lifestyle modification. So often GERD could be related to obesity or certain trigger foods, so it's good to have patients maybe keep a diary, try to figure out what the source of the reflux is. In some cases with weight loss, avoiding those spicy foods, avoiding caffeine, eating smaller meals can actually take care of the symptoms. So the initial drug treatment, if you're unable to use lifestyle modification only, is a PPI daily or proton pump inhibitor times 8 weeks. If the patients have nocturnal symptoms, then it can be increased to BID. Sometimes patients may not need to be on a PPI forever, so this treatment initially may help take care of the underlying issue. It could treat whatever the underlying problem might be, which we'll talk about when we get to peptic ulcer disease, and then come off of the PPI. But in patients that have chronic reflux, they may need to be on this long term, in which case they can use a maintenance drug treatment, which you hopefully will be able to find a PPI that works for them, or an H2RA, which we'll talk about as an alternative at the lowest effective dose. It's not recommended to use some of our other agents that we use in nausea and vomiting as long-term therapy for these patients. So first we'll talk about the drug treatment options for GERD. Antacids is probably the easiest place to start. These are widely available over the counter. Patients can get the calcium carbonate, which is Tums, or magnesium products like Mylanta or Milk of Mag over the counter. Dosing is variable, of course, depending on which product you use. Side effects can range from constipation to diarrhea, depending on the product. And electrolyte abnormalities are something to just keep in mind. If patients are taking these a lot, especially if they have renal disease, they can accumulate because they excrete their electrolytes, obviously, through their kidneys. You can also see some drug interactions with these products. They can bind to certain medications like fluoroquinolones, for example, so they should be separated from those. Our H2 antagonists you might see often, the famotidine, ranitidine, Pepcid, and Zantac. There are others, but I didn't list them here. Their dosing is also disease dependent, and there really aren't a lot of side effects. There's headache, sometimes confusion. It's also really important in patients that have renal or hepatic dysfunction to evaluate the dosing of these medications. They are renally excreted, so they have to be dose adjusted for patients that have renal disease. And then one thing I did want to mention especially was drug-drug interactions with a medication called cimetidine. I'm hopeful that this is no longer available anywhere, but I think it actually might be available over some over-the-counter pharmacies and places where you can purchase medications. And this medication has a ton of side effects, and it's something hopefully you haven't seen because people know better, and we're not recommending it as often. It has side effects with a lot of antiviral medications, antibiotic medications. It has interactions with blood pressure medications, seizure medications, warfarin, a lot of major medications that we have our patients on. So I would highly recommend avoiding this at all costs. We have other medications that work well, so avoid cimetidine if you can. The proton pump inhibitors, of course, this is kind of our bread and butter, so I wanted to focus on this area. We have omeprazole or Prilosec, which you can get over the counter or with a prescription. Same goes for Nexium and Prevacid. Protonix and Dexilant are prescription only, and then there is a combination product over the counter called Zegerid. I will say that the only thing to mention here with regards to prescription versus over the counter, obviously we interchange these when patients come into the hospital and go out of the hospital, and so some people have favorites, and that's fine. They can be interchanged. However, if you're sending somebody home on one and you want to say, hey, grab this over the counter, they're really kind of not very cheap. They're a little expensive, so I would recommend evaluating your patients individually and figuring out what kind of insurance they have, because even in some cases it probably may be cheaper to have their insurance pay for it than it may be for them to get it over the counter. So dosing, one of the things I wanted to mention here, the dosing is very simple, and you can use any resource, or they can read the back of the boxes on the when they pick it up from the pharmacy. But timing of administration is really important, and it's drug dependent, and that also would be on their instructions on the back of the box. But I would recommend maybe letting patients know, hey, you need to be taking this sometimes on an empty stomach in most cases, but usually 30 to 60 minutes prior to a meal. So a lot of people will get up in the morning and that'll be the first thing they take before they eat. And then length of therapy is also important. I didn't go into details for every single medication, but it's indication dependent, it's dose dependent, and it's drug dependent. Usually it's anywhere from 4 to 16 weeks on these therapies. And again, this is kind of just a reminder that in reflux, it's not always that you'll be on these medications forever, but it just depends on the reason that you're using the PPI. So in some cases, maybe somebody that has H. pylori, they're going to be on it for a certain period of time. Or maybe if they have peptic ulcer disease, they're going to be on it for a certain period of time. So just monitor the length of therapy for these medications, because a lot of them have end dates. And so it's important to make sure that if the patient is able to come off of it, they can. Side effects include headache, nausea, and diarrhea. And a couple of cautions. I know everybody's kind of heard about these through the grapevine, that it can contribute to C. diff development, which probably is where most of the data is, and all of these kind of cautioned things that I have listed here. So just be careful and cognizant of that in your patients. If it's, again, somebody that doesn't really need it, just take it off. Osteoporosis-related fractures, hypomagnesemia. They've actually seen some incidence of increase of community-acquired pneumonia, and then again some drug-drug interactions, just a caution there. There are a couple key tips when you're starting a patient on it that might be helpful for the patient to know that's been having reflux and are annoyed by their symptoms. It takes several days for this to take effect, and even up to 2 weeks depending on the medication. So you have to tell people to be patient. It's not like a pill that you can take and all of a sudden their nausea or vomiting or reflux just goes away. And then to taper it off when you're discontinuing. A lot of patients have trouble coming off of PPIs because their reflux symptoms recur, and so it's important to let them know when it's time to come off of it that they may have to taper down off their dose, like taking it every other day or once a day instead of twice a day, that kind of thing. Okay, so next we're going to get into peptic ulcer disease. This may be present in the gastric or duodenal gastrointestinal lining, and it's most commonly associated with H. pylori, NSAID-induced ulcerations, or stress. So Helicobacter pylori, or H. pylori as we all know it, is a gram-negative bacillus that's transmitted via infected endoscopes, and it can be diagnosed by breath test, by serum, or by biopsy if you do an endoscopy. And we're going to get into the specific management and treatment of this on a future slide. I also just briefly wanted to mention NSAID-induced and stress-induced peptic ulcer disease. These are a little bit easier to manage, and I've listed that information for you here. Use a PPI for 8 weeks for NSAID, and for stress-induced, you can use a PPI as well. But we more often will be seeing these type of stress-induced situations in the hospital setting, so there are specific guidelines related to using stress ulcer prophylaxis, especially in the ICU and patients that are ventilated, and so that's where you may see that most often. Symptoms associated with peptic ulcer disease include dyspepsia and gastric pain. And just a couple of tips, with the change in pain for patients associated with eating, it might actually help diagnose the type of ulcer they're having. So patients that have pain and nausea and vomiting and they eat and it feels better are usually patients that have duodenal ulcers. People that have more pain or more nausea and vomiting after they eat will more often have gastric peptic ulcers. Okay, so first to talk about the H. pylori treatment. So usually, historically, we've seen a triple therapy with a PPI plus 2 antibiotics. However, in other countries and now in our own, we've seen an increase in use of something called a quadruple therapy due to treatment failure associated with the clarithromycin. So ideally, we would be able to evaluate our patients for risk factors for resistance to clarithromycin, which might be a prior exposure to a macrolide antibiotic in kind of the recent past, or high local clarithromycin resistance rates. In some cases, patients or areas will just assume that they have a high resistance rate and they'll just start using a quadruple therapy. So I would recommend that you talk to whichever institution you end up working for and kind of their standard of practice there. So the triple therapy is for 14 days, and that's a PPI BID plus amoxicillin and plus clarithromycin. You can replace either of those antibiotics with metronidazole if needed for allergies. And then quadruple therapy is for 10 to 14 days, and here you would use a PPI BID plus bismuth subsalicylate QID, metronidazole QID, and tetracycline QID. In either of these cases, you could substitute an H2RA for the PPI if needed, but the PPI is ideal. I also wanted to mention cytoprotective drugs, and this is actually something that you would see more often in that NSAID-induced peptic ulcer disease that I mentioned at the beginning. That's where you're going to be using that 8 weeks of a PPI. However, in some cases where the NSAID maybe can't be discontinued, you may see cytoprotective drugs, or maybe patients that are on long-term steroids that cause gastric irritation. These two medications are really solely for that purpose, is to protect the lining of the stomach. So Cytotec, the first one, has side effects including diarrhea and abdominal pain, but really what I want to highlight about this is that there's an enormous boxed warning, and that they use this for abortion, and it's really obviously a category X drug, and so it shouldn't really be used in any patients that are of childbearing age anyway, so just be extremely acutely aware of that. Sucralfate or Carafate has a side effect of constipation. It should be cautioned in renal impairment, and it should also be separated from other medications from 2 hours before and 4 hours after, because it can bind the medications as well. So nausea and vomiting, we're going to move in here. There's obviously a bazillion causes for nausea and vomiting. I can't even begin to list them all. Here's a few of them: infectious, food, pregnancy, chemotherapeutic agents, motion sickness, GI diseases, and lots of medications. For example, I was just going to mention some of the highlights. Metformin, we see a lot of GI disturbance with metformin, which usually goes away after a period of time. We see a lot of nausea and vomiting with our opioids, which tends to get better, but we will often pre-treat to try to take care of that, but it's extremely common. Every medication has a side effect of nausea and vomiting. Treatment of nausea and vomiting, of course, is to identify the underlying cause, and if you can address that, then try to do that. Otherwise, there are certain medications that are better for certain indications, which we'll go through. You can also consider non-pharmacological therapies in patients depending on the reason, if it's food especially. Small meals, low-fat diet, avoiding triggers, sometimes that can make things worse. It can also mean that somebody, for example, has like a peptic ulcer disease or a reflux, and they're having nausea and vomiting associated with that. So pregnancy-associated nausea and vomiting is something very common. I'm sure you get lots of questions about. Of course, we all want to use conservative management first in these patients, trying to identify triggers if we can. Some patients will even do hypnosis or those bands that they wear on their wrists. Anything that we can do to avoid medications in these patients is great. Some people will use ginger, and it's recommended to use ginger-containing foods or drinks. With regards to supplements like this, you have to be really careful because these aren't FDA approved, and so we can't necessarily validate their safety, and we also don't have as much data with regard to drug-drug interactions. So I caution its use regardless if they're pregnant or not, and if given, no more than 1 to 1.5 grams divided over 24 hours is recommended. There's also vitamin B6 plus doxylamine, which is an antihistamine, or it's also called Diclegis, and it is the only FDA-approved medication for this indication, and the dose is 2 tablets nightly. This is an all-inclusive list of most of the nausea and vomiting treatment options that we have available. We already talked about ginger, which can technically be used in any population. We have cannabinoid derivatives, antihistamines, phenothiazines, 5-HT3 receptor antagonists, corticosteroids, and benzodiazepines. Each of these kind of have a different niche or indication that they're best used for, and so we'll talk about each of those as we go through each of the medications together. Okay, so first we'll start with the antihistamines. You'll see them listed here, and the mechanism of action is that it has its antiemetic properties from an anticholinergic blockade at the histamine 1 receptor, and this decreases exocrine gland secretion. We see these most often used in motion sickness, so the Dramamine and the Antivert. Dramamine is a very common motion sickness medication that's available over the counter. People will use it for flying or for cruises. There are side effects associated with antihistamine, which we know, the anticholinergic side effects like sedation, dry mouth, blurred vision, urinary retention, and sometimes in pediatric patients we actually see a paradoxical excitation, and so they get really hyper, so just be aware of that. It should be cautioned in narrow angle glaucoma, benign prostatic hypertrophy, or anything that causes urinary retention, and then especially in the elderly. I'll just put a plug here. If we can avoid any antihistamines in the elderly, that is ideal. And because of these side effects like blurred vision and urinary retention, it puts them at a really high risk for falls. So I would probably recommend against using any of these agents in our elderly patients. So phenothiazines, we have compazine and Phenergan. They block dopamine receptors at the chemoreceptor trigger zone, as well as receptors acetylcholine A1 and H1. It's indicated as an antiemetic for a variety of causes. And what I'll say about this is I usually, in my experience, will see this used second or third line. However, it is most useful for treatment of nausea and vomiting versus prevention. So say, for example, you've already tried Zofran in a patient and, maybe some other antiemetic agent, and now they're actively vomiting and you need something to use, this would be an agent for that. And so side effects associated with this include drowsiness, EPS, agranulocytosis, and some anticholinergic effects. And it's contraindicated in Parkinson's disease, narrow angle glaucoma, bone marrow depression, severe cardiovascular or hepatic disease as well. And long-term use is not recommended. I'll also put a plug here if you ever use this in the hospital setting. Phenergan, for example, administration through an IV can be very dangerous if their IV is not working perfectly because they can have extravasation and it can also cause tissue necrosis because of that. So I would be very cautious if you ever have to use it in that situation. But again, this is really going to be something that you might see used more like in a second or third line when a patient is refractory to something else or are having active nausea and vomiting that maybe your first line didn't work for. Just for completeness, I wanted to include a slide on our only cannabinoid derivative, dronabinol. Its indication is generally as an alternative in chemotherapy-induced nausea and vomiting. I have seen it used in the operative setting, but it's more useful for treatment versus prevention. It should be cautioned in patients with a history of seizure disorders. It does have a lot of side effects, including psychiatric effects, tachycardia, hypotension, seizures, and of course an abuse potential. So for the reasons that you see highlighted here that are bolded, you don't see this used very often. But just for completeness sake, again, I wanted to include it. So the 5-HT3 receptor antagonists, there are many of these, but of course I have listed kind of our bread and butter ondansetron or Zofran, which we see all the time. It blocks serotonin peripherally in the GI system and centrally at the chemoreceptor trigger zone. Its indication is first line for patients with chemotherapy-induced nausea, vomiting, or post-op nausea and vomiting prevention. This is like the best agent to just give ahead of time if you know that something might cause nausea and vomiting, and it really works best if you really do give it ahead of time. It's hard to use this as a kind of a catch-up medication if somebody's already not feeling well. Second line, it can be used for patients that have cyclic vomiting, pregnancy off-label, and gastroenteritis. Side effects include constipation, headache, fatigue, dizziness, diarrhea, and one that we monitor probably most frequently is for QT prolongation when it's given with other medications that can cause QT prolongation. Corticosteroids, again, for completeness, I wanted to include this. The mechanism of action specifically for nausea and vomiting is unknown. You most often see dexamethasone used, however, methylprednisolone may be also used, and it's indicated for chemotherapy-induced nausea and vomiting. Side effects, of course, include glucose elevation, insomnia, anxiety, and it can cause gastric upset, unfortunately. Benzodiazepines, the mechanism of action binds to the receptors on the postsynaptic GABA neuron, and it enhances the inhibitory GABA effect, causing less excitable neuronal state and stabilization. It's indicated for anticipatory or breakthrough nausea and vomiting and may be more useful in patients that have refractory chemotherapy-induced nausea and vomiting. You can see amnesia with this, sedation and CNS depression, drug abuse, of course, and it's an enormous fall risk in the elderly, and for that reason should be cautioned. I put caution especially for these two things, elderly and abuse potential. I really don't see this used very often for nausea and vomiting, however, for completeness, it's So drug-induced nausea and vomiting, again, this is one of those things I was mentioning before, like with metformin or opioids. We see it a lot. It usually will respond well to antiemetics when you see this, and you've identified that it's a drug-induced nausea and vomiting case. And of course, discontinuing those inducing agents would be ideal if we can. Sometimes we know that things are going to get better, like with metformin, or you can titrate the dose a little bit slower. You can think about extended release versus immediate release. So there are ways around it. Of course, the most commonly used is the 5-HT3 antagonist, that's Zofran, and that's because it has extremely low side effect profile and most people tolerate it really well. Like nobody has an allergy to Zofran. Antihistamines might be useful long term if that's something that if it's a drug that they're on that they're going to be on for a really long time and we're trying to increase their tolerability. And again, dronabinol, that was the cannabinoid derivative, is only approved in chemo-induced nausea, and it can be used as an appetite stimulant. Motion sickness, antihistamines are good for this, acting on the vestibular system to control nausea and vomiting. It has a rapid onset with antihistamines and a long effect, and again, we use the dimenhydrinate or the meclizine most commonly in these patients. So Dramamine is what you'll see most often. It's important to remind people to take these medications before they start traveling because, again, it's not great for catching up once you already don't feel good. So it should be taken pre-travel. And then, of course, scope patches we use for this as well. There are many, many, many anticholinergic side effects. So a lot of times we'll have patients like try this at home before they go on their awesome cruise and find out that they have terrible side effects that they can't tolerate. It's also contraindicated with narrow angle glaucoma, chronic lung disease, and prostatic hypertrophy. Briefly, I want to go over gastroparesis. We're almost done. This is something that we see related to the muscles in the GI tract that don't function normally. It just slows the process of your gut motility, interferes with digestion. There is no cure for this. It's only symptom management, and it's often associated with really significant vomiting. Risk factors are many. However, I will highlight the first one for diabetes. That is really where we see this most often, and it is recurrent in those patients, especially those that are not controlled well. So you may see this in patients that have diabetes that return often with these symptoms. There is non-pharmacologic management. You can use smoking cessation, actually, weight loss, which is supposed to help a lot, and then the same kind of non-pharm for the other disease states we talked about. So avoiding those irritants like alcohol, big meals, making them smaller, fatty or spicy foods, and then not eating right before you go to bed. Briefly, I'll highlight two of the most common prokinetic agents. The first is metoclopramide or Reglan, which you may have seen also used as a medication for nausea and vomiting. It does work for that as well. Its mechanism of action is dopamine antagonist, and it enhances acetylcholine activity in the GI tract. It accelerates gastric emptying and increases lower esophageal sphincter pressure, and that's why we specifically use it in gastroparesis. It does have side effects like EPS symptoms, drowsiness, depression, and it can elevate aldosterone, and it's contraindicated in patients with Parkinson's disease or mechanical obstruction. For the reasons of the side effects that I've listed, you may not see this used often in the nausea and vomiting population because I didn't mention it there, but it does work for that. And because that it has this mechanism of action to accelerate gastric emptying, it's usually a first-line prokinetic agent in gastroparesis. The other agent you may see is erythromycin, which is actually a macrolide antibiotic. Its mechanism for its use here is really unknown. It does have side effects like drug-drug interactions, and it can prolong the QT. And it's contraindicated in patients who have an allergy to macrolide antibiotics or in certain combinations due to drug-drug interactions.
Diarrhea is defined as either an increase in the number of bowel movements each day or a change in the consistency of bowel movements from being more watery or loose than normal. From a pathophysiology standpoint, what is happening is something is causing the intestines to push the stool through the bowels too quickly for the water content to be reabsorbed into the body like it normally does. Most common cause is viral, but it can also be caused by bacteria, lactose intolerance, and certain foods and medications. The most important step in treating diarrhea is maintaining adequate hydration and replenishing electrolyte loss. This is especially important in patients who are at high risk for dehydration, so our pediatric and elderly patients. Rehydration is usually accomplished via Gatorade or oral rehydration solutions like Pedialyte. Water can be sufficient as well, although the source has no electrolytes within it. Other options include removing offending medications, making dietary changes, and the BRAT diet. Here is a list of medications that can help with diarrhea. Pepto-Bismol is an OTC product, usually administered as a solution. It contains a salicylate, which is essentially aspirin. Therefore, it needs to be avoided in children due to the risk of Reye syndrome, as well as pregnancy and anyone who has an aspirin allergy. You would also want to avoid concomitant use with aspirin to lower the risk of toxicity. Imodium or loperamide is also available over the counter. This product is a synthetic opioid that only works within the GI tract to slow down GI motility. Counseling is very important here because at high doses it can cause QTC prolongation, and it can be abused as well because at higher doses it loses its selectivity for the GI tract and can cause other opioid effects throughout the body. Lomotil is a prescription-only medication, and it is actually a controlled substance. It is the combination of diphenoxylate, which is a synthetic opioid that acts similarly to loperamide, and then atropine. This doesn't really have any effect on diarrhea. It does have some anticholinergic effects, and that helps prevent abuse. These last two medications, loperamide and Lomotil, they should not be used alone in infectious diarrhea or in children who are less than 2 years old. Traveler's diarrhea may develop in patients from resource-rich settings during or within 10 days of returning from travel to resource-limited countries or regions. This is mostly caused by the bacteria E. coli, and travelers can try to prevent this from happening by cautious selection of food or drink, and bismuth subsalicylate can also be used prophylactically 4 times a day. It's given with each meal and then again at bedtime. There is a limited role for antibiotics in prevention of traveler's diarrhea, but it could be considered in patients who are immunocompromised. To treat traveler's diarrhea, fluid replacement is still key. In patients who have mild to moderate diarrhea, loperamide or diphenoxylate can be used, but they should not be used in dysentery, which is when you'll also see bloody stool or fever. Antibiotics are generally not recommended since symptoms tend to resolve on their own, and this increases antibiotic resistance, but they are used in severe diarrhea or dysentery. The technical definition of constipation is infrequent stool passage or difficulty passing stools. There are a number of potential causes such as lifestyle, diet, pregnancy, age, certain comorbidities, and a variety of medications as well that are listed here. Non-pharmacological treatment of constipation includes getting adequate fluid and fiber intake, increasing physical activity, and practicing proper toileting hygiene, which includes having a regular schedule, location, and not delaying using the restroom when you feel like you need to. In patients who have mild and recurrent issues with constipation, generally increasing fluid and fiber intake are very easy fixes. Most Americans only get around 10 to 20 grams of fiber each day, and you can see the recommended daily intake is much higher than this. A couple key counseling points for patients who are trying to increase their fiber intake is that, number one, we prefer food-based sources of fiber over things like fiber gummies that are available over the counter. And then also, as they increase their fiber intake, they should do so slowly to avoid cramping and bloating. Typically, it's recommended to increase by about 5-gram increments each week. There are a number of medications available to help treat constipation, and most of these are over the counter. Generally, they're thought to be equally efficacious, with the main difference being their onset of action, which you can see in the table differs greatly between products. This is the key thing to ask yourself when you're determining what to recommend for a patient. For instance, sodium phosphate enemas or glycerin suppositories tend to work within minutes to an hour, whereas bisacodyl may work within hours, but Docusator Miralax could take days to really work. Outside of the timing, they are considered equally efficacious for the most part, and generally first-line options would start with products that are given by mouth, and then as constipation is more severe, you would consider using rectal options like suppositories and enemas. Our bulk-forming agents work by creating a gel-like matrix in the stool that helps to soak up fluid and create bulk, which stimulates peristalsis. These are good for long-term use, and they also contain fiber. And then our osmotic agents like Miralax help to draw water into the colon and fecal matter to stimulate bowel movements. However, you do need to watch electrolytes with long-term use. Emollients are also known as stool softeners, and they help to mix water and fat-based contents in our stool to soften it. These are typically used as prevention for constipation or if the patient has difficulty with straining. They're often preferred as first-line agents in pregnancy. Mineral oil works by coating the bowels with a waterproof film to help keep moisture locked into the stool. This needs to be avoided in elderly patients and others at risk for aspiration. Stimulants work by irritating the GI tract to stimulate GI motility, but they can cause cramping. And then our saline-based laxatives help to draw water into the intestines, but magnesium-based products should be avoided in renal impairment because the magnesium can accumulate in those patients. Unfortunately, IBS is a very poorly understood disorder with no clear pathophysiology linking together all cases. Historically, it's thought of as a brain-gut disorder due to a high association between IBS and anxiety and depression symptoms. Some potential causes include changes to intestinal microbiome after an infection, changes to sensory function of the intestines causing rapid or slow motor function of the gut, immunological reactions, and genetic predisposition. IBS can be divided into subtypes depending on if the patient has diarrhea or constipation as their dominant issue. Diagnosis is based on the Rome 4 criteria, so you must have recurrent abdominal pain along with 2 of the 3 symptoms that are listed here and no warning signs. So these would be evidence of a GI bleed, unintentional weight loss, or a family history of colorectal cancer. Typically, IBS is a diagnosis of exclusion, so we'll rule out other things first, and then if you can't find a cause of that patient's symptoms, they might be diagnosed with IBS after that. Treatment of IBS usually begins by trying to find a trigger for the patient's symptoms, which most patients can find out and can avoid. If this is unsuccessful, we'll often use medications next that we previously discussed in the diarrhea and constipation sections, depending on the subtype of IBS, since these medications are relatively inexpensive and readily available over the counter. Afterwards, we may consider treatment with prescription medications that are specifically indicated for IBS, which are listed here. Linzess and Amitiza are available for IBS-C, whereas Lotronex, Xifaxan, and Viberzi are indicated for IBS-D. Bentyl is an option for patients with significant abdominal discomfort in either subtype, and although not discussed on this slide, antidepressants and anxiolytics, as well as cognitive behavioral therapy, are all commonly utilized for IBS as well, especially when it's thought that a psychosomatic component may be involved.
So some medications of interest for this lecture are going to be things like topical emollients, steroids, salicylic acid, maybe some different antibiotics, coal tar products, and then some more rare medications such as isotretinoin, anthralin, and then tazarotene. Sorry about that. So just to start off, I want to talk a little bit about the functions of the skin. So it's the largest organ of your body. It has a lot of different roles, so it's a barrier, basically, for everything. It thermoregulates, so it helps, we kind of get goosebumps whenever we are cold. It helps release sweat whenever we're hot. It has a lot to do with sensation, so lots of nerve endings. It helps with the communication and metabolism as well, so it's something that's really important, so we have to take care of it. So the first skin disorder that I want to talk about is atopic dermatitis.
And there are approved biologic agents for atopic dermatitis. These are not necessarily something you yourself would be prescribing, as dermatology is going to be the one managing these medications. However, it is important to be familiar with these medications because your patients may present while on these agents.
So another name for atopic dermatitis that's probably more common to you is eczema. So eczema is a chronic inflammatory skin condition. It usually occurs on the flexor surface or parts of the skin that touch where a joint bends. So kind of think maybe like inside of the elbows, back of the knees, and areas like that for eczema. It's usually part of the allergic triad. You can usually see it's pruritus, erythematous, scaly skin lesions, and I talked about the flexural surfaces already. So to diagnose this, you kind of need to have itchy skin, and then you need to have at least 3 of the following. So you need to have a history of asthma or allergic rhinitis, a history of flexural involvement, a history of generalized dry skin, onset of rash prior to 2 years of old, and then visible flexural dermatitis. So like I said, you just need 3 of those factors. So really think kind of someone that's had maybe some sort of inflammatory process in the past, and flexural is really what I want to emphasize here. There are 3 clinical phases, so there's acute, subacute, and then chronic. And the goal is for eczema, obviously, to manage the symptoms and try to decrease the time between flare-ups for patients. As far as management of eczema, the first step, of course, is to try to control the dry skin. So for this, we'll use topical emollients, which I'll go over a little bit more. And then the first line treatment beyond emollients are topical corticosteroids. So they come in a variety of potencies, which we'll go over. And it's one thing to consider, so if it's a more sensitive area, such as the groin, you're obviously going to want to use a milder potency. But if someone has something like lichenification, which is a skin condition that occurs in response to excessive itching or rubbing, the patients get this kind of leathery thickness to their skin. You're going to have to probably use a high potency corticosteroid in that case. And then you also may need to consider occlusive therapy. And then if you're able, we like to try to get them off of the topical corticosteroids or the occlusive therapy and taper them back down to the emollient therapy alone, if possible. So some other things to consider, you want to tell patients to try warm, not hot showers with maybe some sort of emollient wash to help them. They need to pat dry when they get out of the shower instead of rubbing, and then they can put on emollients immediately after the shower. So to some topical emollients to think about, so the thickest creams are the Cetaphil and Eucerin. Ointment, so Aquaphor is really good. It has a lot of moisture in it, and then petroleum jelly, obviously. And then there's ceramide lipids, which are CeraVe and Restoraderm. The ointments are often more potent than the creams just because the vehicles that they're made in allow them to be that way. And let me So these are the topical corticosteroids listed by potency. I tried to make it pretty easy to see based on this table. One thing to point out, hydrocortisone 0.5 and 1% are both available over the counter. They usually are not covered by insurances, so that's important to keep in mind. So if you want to give someone the OTC version of hydrocortisone, they will have to pay for it. And you can see these just kind of increase in potency. And then these are the ultra high potency ones. So it's important to remember that even though these are topical corticosteroids, they are not without side effects. Some of the ultra high ones can actually even have systemic side effects, so you have to look out for things such as Cushing syndrome and like adrenal suppression. Otherwise, you need to watch out for things like thinning of the skin, cutaneous purpura. You can have some folliculitis. And there may be something like a scaly eruption with use of topical corticosteroids. So really the best instructions that you can give a patient that's going to apply a topical corticosteroid for eczema is to apply a thin layer just where it's needed, so usually in the folds of the skin. And remember, increased potency leads to increased side effects. And as far as recommending one over the other in the same potency class, there's really not a difference besides price. So you'll just have to get an idea of that from possibly the patient's insurance or the pharmacy.
And there are approved biologic agents for atopic dermatitis. These are not necessarily something you yourself would be prescribing, as dermatology is going to be the one managing these medications. However, it is important to be familiar with these medications because your patients may present while on these agents.
Next, I want to talk about psoriasis. So psoriasis is a chronic inflammatory disorder. It usually is multi-system with both skin and joint involvement. It's usually associated with other kind of inflammatory processes or autoimmune diseases such as inflammatory bowel disease, diabetes, metabolic syndrome, or coronary artery disease. It's notable for sharply demarcated scaly erythematous patches, papules, and plaques. So you can kind of see the plaque here on this picture to the right, what that will look like. It's usually a dry, thin, silvery white scale, and they tend to be symmetrically distributed in patients. Plaque psoriasis is the most common kind of psoriasis, but you can also see inverse psoriasis, which is in the skin folds and moisture, erythrodermic, which is the entire body surface area, pustular, which, like its name suggests, is with pustules. Patients can also have a fever and they may appear toxic. Guttate psoriasis, which is spelled Guttate if you want to look it up, is a dewdrop-like appearance. And then there's nail disease, so inflammation in the nail beds. And like I mentioned, this can be disfiguring, painful, and pruritic. It can cause painful fissuring just because of how deep psoriasis goes. This causes patients a lot of kind of psychosocial morbidity and distress because it is rather disfiguring, so that's something to keep in mind. As far as treatment of psoriasis, it's really based on the disease severity and what other comorbidities they have, what they're willing to take as far as price and convenience, and how well they respond. So initial choice of therapy is usually topical or systemic. For patients with mild to moderate psoriasis, we kind of want to stick to those topical corticosteroids or emollients we mentioned back when we were talking about eczema. For moderate to severe patients, it's when we get into more of the retinoids, methotrexate, cyclosporin, or biologics. And a lot of those medications you would want to refer to a rheumatologist to prescribe. So that's just something to keep in mind for your more severe patient. So some topical options you can see listed there, and then the other options. As far as biologics, I just wanted to list a few so you'll be familiar with them. So those would be things like Enbrel, Humira, which you've probably seen heavily advertised on TV, Remicade, Cimzia, Simponi, Stelara, Cosentyx, and Taltz. And like I said, a rheumatologist would be more familiar with those and should probably get a referral in that case. So next I want to talk about tinea. So these are a group of skin diseases caused by fungus, and the different names just come from different locations on the body. So we'll start with tinea capitis, which is ringworm of the scalp. The treatment options for this are griseofulvin, which is an oral agent that must be taken with a high-fat meal. So we like to recommend things like whole milk, cheese, or ice cream, especially for children. And then bi-weekly shampooing with a sporicidal shampoo. So a sporicidal shampoo example would be something such as selenium sulfide shampoo or a ketoconazole shampoo. The treatment should be for 2 to 4 months, or at least 2 weeks after you obtain laboratory examinations, and then just kind of monitor to see how patients do, make sure they're not having any side effects from the medication, and that they're using the shampoo appropriately. Tinea corporis is fungal ringworm infection of the skin, probably what we're most familiar with when we think of ringworm. It's very distinct, as you can see in the picture to the right. It does have the annular lesion with raised borders and center clearing. The preferred treatment options are the topical antifungals, especially the azoles such as miconazole or clotrimazole. You can try some of these other options such as terpenophene if you so wish, and then depending on what agent you choose, the treatment can be from 1 to 3 weeks, and then some of the orals I believe are a little bit longer. But you can kind of choose your treatment and then decide how long you want to treat based on the recommendations. Tinea cruris is jock itch. It's a superficial fungal infection of the groin, upper thighs, and interinguinous folds. The treatment options are the same medications that you want to use in tinea corporis, and you usually apply the treatment once to twice per day for 3 to 4 weeks. Tinea pedis is athlete's foot, so fungal infection of the feet, usually kind of associated with like group showering and other things like that. Treatment options are the same as tinea corporis, but you must treat this for 4 weeks. Tinea versicolor is a yeast infection of the skin, so probably a little bit of a different organism than we think of for tinea corporis. Treatment options include topical application of selenium sulfide shampoo, or you can use a topical antifungal. So I just kind of included the directions for applying selenium sulfide and how long. And then if you choose to do a topical azoles, you can use it twice a day for 2 to 4 weeks. Tinea unguium is the fungal infection of the nail. Treatment options include systemic antifungal medication. Terbinafine typically does a little bit better than griseofulvin. One thing to point out with terbinafine, if you do decide to prescribe that, patients need to get liver function tests if they're going to be on it for a prolonged period of time. But itraconazole may be used for first-line therapy in adults. So they have looked at topical therapies for this treatment as well, but studies have shown that systemic therapy really works a little bit better for these kind of nail bed fungal infections. So systemic therapy is really first line. So next we'll move into acne. So acne is the most common skin disorder in the United States. It's a chronic inflammatory dermatosis. You can have open and or closed comedones, inflammatory lesions, which we can see here, different examples, and then Propionobacterium acnes is the gram-positive human skin commensal that kind of gets into your pores. It's a bacteria and is one of the causes of acne. So there's about a lifetime prevalence, about 90%, and 10% of the patients that experience acne have an encounter with a primary care physician. Assessment and grading, so there's really no consensus on a single or best grading or classification system. So you can just be consistent with what you use as far as assessment and grading. So you can look at the number, size, and extent of the lesions, and then kind of assess the severity. But if you are going to use some sort of scoring tool, just make sure you use it consistently for all of your patients. So as far as factors in acne formation, there's an increase in sebum production, which is a response to hormonal influences. So that's usually why it starts kind of in a puberty. There's increased sloughing of the keratocytes, which leads to clumping and the clogging of the pores. I kind of talked about the bacterial growth, so it is a natural part of human skin, but when it gets into the pores with the increase in keratinocytes, it can lead to this like acne inflammatory reaction. And I kind of just summed it up all at the bottom there. You have all of these factors leading to an inflammatory response that causes acne. So some external factors that could contribute to acne are things like mechanical obstruction. So if you think about someone that wears a hat a lot or a helmet, they may have like a line of acne across their forehead. Occupational exposure, so if you're in an area that may have a lot of like smoke or other like chemicals or something in the air, think about that. Medications, I think a lot about steroids in this category. Cosmetics such as makeup and like concealer and everything can actually make acne worse. And then other environmental factors such as humidity, just because if you think about it, it doesn't let your pores breathe and can lead to increased sweating. So the goals of therapy for acne are really long-term control, alleviation of symptoms. We want to try to prevent future breakouts and then prevent scarring. So when you're going to consider a treatment for acne for your patients, you really need to think about several different things. So skin type determines what vehicle of agent you're going to want to use, and I'll talk more about that. The types of lesions can guide therapy, and then if they have scarring, you want to think about being more aggressive and maybe considering a systemic therapy. So drug-induced acne, I kind of touched on this a little bit already, but we do think a lot about systemic corticosteroids if they're on an anti-epileptic such as phenytoin, things like lithium, isoniazid, any sort of androgen or cyclosporin could be a major factor in causing acne. So we want to assess their med lists for these medications. Topical treatment forms, so I kind of talked about this a little bit. So creams are usually white and they're somewhat greasy. Gels are clear and more jelly-like. They're typically not as moisturizing as things like creams and ointments. They can actually be a little bit drying. Lotions are usually milky and have a water alcohol base. Solutions are clear and typically contain alcohol. Ointments are usually translucent, and these are the greasiest of the formulations and can be very occlusive, so they're rarely used for acne. You think about ointments more, definitely for dry skin as opposed to acne. So you kind of want to identify what type of skin your patient has. So if they're oily, you're going to want to stay more with the drying effects, such as the gels and the solutions. A normal skin, you might consider adding on maybe a lotion or a cream because they're less drying. And then if they have more of a dry skin, you definitely want to consider a lotion or a cream because that's going to help with moisturization as well as with the acne. So the different treatment options are the topical exfoliants such as salicylic acid, sulfur, and retinoids. There's topical antibacterial agents which target the bacteria that gets in the pores. There's oral antibiotics, hormonal therapy, and then some other options as well. Topical agents are typically sufficient for most, but you need to consider systemic therapy for those who have deep nodules or cysts. So first I want to talk about salicylic acid. So its mechanism of action is that it is a comedolytic. So it kind of breaks up the comedone that appears on the skin and helps with the redness and basically helps dry up the pore. The dose is typically 0.5 to 2% and you apply it once or twice a day. And then adverse effects can be skin dryness and then irritation. Benzoyl peroxide, so this has bacteriostatic and cytal activity and is also comedolytic. This can be either over-the-counter or prescription, depending on the dose and the formulation that you want. It's applied once or twice a day, and they recommend to do it to cool, clean, dry skin. So typically they'll say, wash your face and then let it dry and cool down, and then apply this benzoyl peroxide. And then adverse effects from this, you can have contact dermatitis. The big thing that people probably don't think about, it does have peroxide in it, so it can bleach your clothes, linens, and towels. So make sure you wash your hands very thoroughly after you use this. So then there's the kind of the topical antibiotics with combination of the salicylic acid. So these are things like benzoyl peroxide or Clearasil, clindamycin. There's the benzocaine cream, which you can mix together, which is the benzoyl peroxide and the clindamycin. And you can apply these twice a day. So the one thing with these are they do kind of have erratic and unpredictable penetration. They can be used in combination with a topical retinoid or as a maintenance treatment after you give someone oral antibiotics. Benzomycin is refrigerated and it typically has a 3-month expiration. And then the combination with the benzoyl peroxide and the salicylic acid helps to prevent resistance from the bacteria. Topical retinoids. So these are things like tretinoin, adapalene, tazarotene, and then the clindamycin-tretinoin combo. So their mechanism of action is also a comedolytic and increased cell turnover, and it leads to extrusion of existing comedones and inhibition. This is usually applied at bedtime after washing, and side effects include irritation, dryness, peeling, erythema, and it can be teratogenic. So you want to make sure of the pregnancy status of your patients. So one thing I want to point out, so keratinization is the conversion of squamous epithelial cells to keratinized cells, like nails. So you have strong nails that are keratinized cells. Some of these topical retinoids can lead to abnormal keratinization, comedone formation, and then increased turnover of follicular cells and comedone extrusion. So with the mechanism of action of topical retinoids, acne can actually get worse before it gets better. So you want to make sure that you counsel your patients on this if you're going to give them a topical retinoid. They may see an initial worsening of their acne, but it's kind of a precursor to it getting better. And these should not be used with other topical agents that may have a worsening drying effect, because they will dry you out really badly. So next is definitely more of an more serious treatment option. So this is isotretinoin or Accutane. It is an oral medication and it's really only for severe cystic acne. So its mechanism of action, it decreases sebum production, gland size, and abnormal keratinization. You can see the dose there, and it's taken with food for 15 to 20 weeks. So adverse effects, it can cause some dry skin, emotional disturbances, hyperlipidemia, gastrointestinal, and then maybe some visual changes as well. It can be considered curative, especially for the severe cystic acne. So it is effective, but it definitely comes with a slew of adverse effects. Another thing, so this is pregnancy category X. It causes major fetal abnormalities. It can cause spontaneous abortion, low IQ. So it's definitely important that patients receive a pregnancy test prior to starting Accutane and then monthly afterwards. They need to consider using 2 forms of birth control. And then you have to go through this I-Pledge program in order to prescribe Accutane. So the provider must be registered, and you have to make sure to check their LFTs and lipids prior to the start of therapy and then periodically. So as far as LFT elevation, LFTs were actually elevated in about 15% of patients in clinical trials. It's usually self-limiting. It doesn't really lead to any sort of permanent liver damage. But if the LFTs do not resolve, you kind of have to discontinue it. And this is something that's usually prescribed by a dermatologist. Just a little bit more about the iPledge program. So the provider has to be signed up, and the patient actually has to get an iPledge card, and that has to be taken to the pharmacy for each dispense, and the pharmacy has to enter how many boxes they're getting. They have to make sure that the appropriate lab work's done. So it's definitely a large process to prescribe this, but it could be curative for some patients. Hormonal therapy. So hormonal therapy is recommended for mild to moderate acne in women who are also requiring birth control, kind of a 2-for-1. And how this works is it decreases androgen production by the ovaries. So the two birth controls that currently have approval are orthotricycline and orthocycline. And typically improvement seen in about 3 to 6 months after a patient starts their hormonal therapy. Oral antibiotics, so these can be combined with topical agents for about 6 months and should be reserved for appropriate patients, because obviously we don't want to have patients on antibiotics if they don't really need them. So it is for more of a moderate to severe acne. The main class that's recommended are the tetracycline, so either minocycline or doxycycline. So you do want to do them daily over 6 months, and then you can kind of taper them off. Some of the cautions, so you need to watch out in combination with birth control because it can lessen the effectiveness. They should not be used in pregnant patients, and they should also not be used in children less than 8 years of age. So some of the adverse effects obviously are bacterial resistance. They can cause some GI upset. Patients, because they're going to be on a longer course of antibiotics, may develop like a candidiasis, such as a thrush. It can lead to increased photosensitivity, so you need to make sure that patients are applying sunscreen to further protect their skin. And then the one thing as far as administration, so we probably talked about this in the antibiotic lecture, but you can't give doxycycline and minocycline at the same time as di- or trivalent cations. So things like calcium and iron need to be given at least 2 to 3 hours apart from when you're going to give the antibiotic. And then as far as miscellaneous, so it is recommended to try to avoid oil-containing cosmetics. And then try to avoid doing multiple layers of cosmetics. So I know a lot of people do like the foundation and the highlighter and different things like that. So in a patient with bad acne problems, that's definitely not recommended. Patients should not be avoiding moisturizers because of the fear of the extra occlusion of the skin. It's important to keep the skin moist and prevent it from getting dried out, especially if you're using some of these treatment options. Hair should be washed at least 2 times a week. They should try having a balanced diet, drinking plenty of water, and exercising. And it's important to tell patients not to pop or pinch their pimples. Some other miscellaneous agents that I just wanted to briefly mention. You can use spironolactone in some patients, and it's shown to decrease sebum productions. You can consider using Azelix. It does have a skin lightening effect, so it's good for hyperpigmentation. And then you could consider maybe an anti-androgen. And then another option that is not a medication is, of course, IND, but once again, that would probably be reserved for more severe cases. So this is just a treatment overview, talking about the severity, the main kind of pathophysiology. So typically the comedones are the lone culprit in mild acne, and then as you get up, as you increase in severity, you get more of the papular and pustule lesions, and then you can get more of the nodulocystic lesions when you get into severe acne. So then I just summed up what treatment options you might want to consider in each of these situations. Therapies are primarily used to prevent formation of new lesions, and it may take up to 8 weeks to see visible results as far as getting rid of the old lesions, so that's important to counsel patients on. and to tell them to continue to use their treatment, to not give up if they don't see an initial result. So